we're going to talk about 4 very interesting cases which presented not typically. And you know that hypertension presentation in children is often vague. So they presented in different manner. And then at the end, we found very interesting diagnosis. So this is the whole spectrum. So when we talk about hypertension or blood pressure regulation, there are 2 major factors which are there. One, of course, is how much is the cardiac output and how much is the peripheral vascular resistance. So these are the 2 major determinants, and many of the endocrine factors will play a role in that perspective. So we know that calcium is a major stimulant as far as the vascular constriction is concerned, and that is why calcium channel blockers are used for management of hypertension. We know that the fluid is largely regulated by multiple endocrine systems. And important factors, of course, are the sodium and the growth hormone. Both play an important role in the fluid regulation per se. Then cardiac contractility and the heart rate is determined largely via the thyroid function. So there are multiple endocrine organs beyond the adrenals which are also involved in the whole perspective. Coming on to the most important part, of course, is the renin, angiotensin, aldosterone system, in which renin basically converts the angiotensin, and then we have the ACE converting into angiotensin 2, which triggers the adrenal production of aldosterone, which is a primary regulator of sodium absorption in the body. Now, adrenals also produce cortisol, which are the trigger as far as catecholamine production. So overall blood pressure regulation involves a number of hormones, and disorders there could cause what we can say, quote unquote, endocrine hypertension. So we all are aware about thyrotoxicosis, increased renin state, which can cause that, hyperaldosteronism, which can be primary or secondary, Cushing syndrome or cortisol excess, excessive catecholamine production like pheochromocytoma, of course, will cause that. And we also know that hypercalcemia and hyperparathyroidism and growth hormone excess can also cause this. So a large number of endocrine disorders are important factors as far as hypertension is concerned. Most of them, be it thyrotoxicosis, be it hypercalcemia, be it growth hormone excess, the symptoms will be clear. The symptoms may actually be quite vague for a aldosterone producing tumor, and this is what we're going to focus more in terms of what we can say, quote unquote, increased aldosterone effect. So either the aldosterone is more, or there is another molecule which is behaving like aldosterone acting on the receptor, or the receptor itself is hyperactive. So that becomes important. So when we talk about increased aldosterone effect, the situation can start right from the production of renin. So you can have scenarios in which there is increased renin production. The classical example we all know is a renal artery stenosis, in which the kidneys feel that there is no blood flow and they are going to push a lot of renin to increase the perfusion, causing hypertension. There could be issues at the level of adrenals, which are producing more aldosterone. And this production can be because of an isolated adrenal adenoma, adrenal hyperplasia, or what we call as a glucocorticoid remediable aldosteronism, which is basically a splicing defect in which the regulation of aldosterone secretion happens via ACTH, and that is going to control that. We can, of course, have a problem in the 11 beta HSD2, which basically shields the mineralocorticoid responsive tissue from the impact of cortisol. So if there is a 11 beta HSD deficiency, like apparent mineralocorticoid excess, you can have a scenario. And similarly, of course, in Cushing's, you have got so much level of cortisol, particularly if it's an ectopic form, which is there. In those scenarios, you may have hypertension, hypokalemic alkalosis, which will happen. So that is actually a apparent mineralocorticoid excess scenario. You can also have increased activation of the epithelial sodium chloride channel, and this also is going to trigger increased activity. The classical example is Liddle syndrome, in which the epithelial sodium chloride channel is more working. You are absorbing more sodium, causing hypertension in that regards. As I said, you can also have aldosterone-like molecule, which have got mineralocorticoid activity. The classical example is DOC, which may be produced in the setting of CAH variants like 11-hydroxylase and 17-hydroxylase. 11-hydroxylase will classically present with XX-DSD and precocious puberty in boys. 17-hydroxylase will present more with XY-DSD and delayed puberty in girls. So these are the overall gamut of scenarios which may be causing an increased aldosterone effect. The problems could be because of a true increase in aldosterone, which would basically be either an adenoma or a hyperplasia. There could be a familial cause like glucocorticoid remediable aldosteronism, which I said is because of the regulation of aldosterone production via ACTH. So it's an unusual production regulation via ACTH. Then you can have a DOC excess because of a tumor or 11 or 17 hydroxylase deficiency. And then finally, you may have no increase in aldosterone, but there is an apparent excess because there is decreased conversion of cortisol to cortisone, resulting in apparent mineralocorticoid excess or a Liddle syndrome. So we'll be discussing about probably 5 to 6 cases if we get time, but there are 4 key cases which will focus about pretty much starting right from adenoma to 17 hydroxylase deficiency to 11 beta HSD deficiency and a level higher also about renal artery stenosis. So we'll talk about a lot of these constellations approaches from that perspective. All of you can go and have a look at our website, learning.gosociety.in, which has got a lot of free resources as well as courses and fellowship programs and diploma in endocrinology, which are available. We do run around 3 programs a month with regards to the journal club, the postgraduate lecture series, and the grand rounds covering these aspects. There are publications which are available both online as well as hard copies and mobile application which can be used for access and point of care. So what we'll do today is to focus about 4 cases after we have the basic understanding of approach so that it becomes easier. So we'll talk about a case of high renin, then adrenal mass, recurrent stroke, and hypertension with nephrocalcinosis. These are 4 very interesting cases. If we get time, we'll talk a bit about 11 hydroxylase and 17 also as case vignettes in that regards. So now in this background of the overall approach for these causes, the questions are, is it really an increased aldosterone effect? If it is an increased aldosterone effect, is it because of an aldosterone excess or an apparent excess? And finally, what is the cause? So as we have discussed that hypertension is particularly common in older individuals. But if you have a young individual and there is a hypertension, we are always worried about that. So if there is an onset of hypertension before 20 years of age, and in children, we know that first you have to exclude all the renal parenchymal and the renovascular causes. Once you have done that, you can think of pheochromocytoma, you can think of coarctation of aorta, then you're talking about an endocrine cause or a low renin cause of hypertension. However, it has now been identified that around 5% of what we call quote unquote essential hypertension in adults is actually because of aldosterone excess. So if you have onset after 20 years also, but requiring 3 or more medications, you have to worry about that this could be a secondary hypertension and do a basic screening for the aldosterone excess in that regards. Now, within a group of individuals who have hypertension, if they have frequent muscle cramps, which basically would mean hypokalemia or hypomagnesemia, if they have features of polyuria and failure to thrive, strong family history, particularly for the autosomal dominant variant, which is the glucocorticoid remediable aldosteronism, and as I said, polyuria and hypokalemic alkalosis, you are thinking more in terms of endocrine hypertension. Now, one concept often people have that everybody who has got a hypokalemia, we are going to think about aldosterone excess. So if the potassium is normal, the chance of aldosterone excess is less. This is untrue. A large number of patients who actually have endocrine hypertension may have normal potassium. And this is an important message to consider, that you have to consider even if the potassium is normal. If the potassium is low, you definitely have to worry, but normal potassium does not exclude the possibility of this group of disorders in that perspective, and that becomes important from that regards. Now, how do we, once we have decided that this is possibly a renin-angiotensin effect, how do you assess the scenarios from there? So essentially, we have already discussed that we have got angiotensinogen, which is converted via renin to angiotensin 1, which is converted via the angiotensin converting enzyme to angiotensin 2, which actually is a very, very important agent as far as fluid regulation is concerned. Angiotensin 2 causes vasoconstriction, increasing blood pressure. It increases aldosterone secretion. It increases thirst. So it has got multiple mechanisms by which it is acting to increase the fluid status overall from that perspective. And this aldosterone will then cause action on the mineralocorticoid receptor to assess. So if we talk about the renin-angiotensin-aldosterone system, the assessment can be done at the level of actual measurement of renin, which is a direct renin assessment, or a plasma renin activity. Now, direct renin is basically an immunoassay. Plasma renin activity is actually a bioassay. So we need to be careful when we differentiate. We'll talk a bit about how they are different and which is preferable in that regards. We, of course, have to measure aldosterone in combination with renin, like we say FT4 TSH, ACTH cortisol, insulin glucose, calcium PTH. Same is that aldo has to be combined with renin to get any meaningful result in that perspective. So the screening investigation essentially for anybody whom you're thinking of endocrine hypertension is an aldosterone along with renin level. Now, what you need to be cautious about that this should be done ideally in the morning around 8 a.m., 2 hours after the patient has waken up. Very importantly, 5 to 15 minutes of sitting posture is important. And because if you're doing particularly a plasma renin activity, which is a bioassay, you should use a pre-chilled tube. Otherwise, you will have a falsely declined level as far as the renin is concerned. Now, we all know that there are two types of assays available. One is the renin and other is the direct renin content. So plasma renin activity is basically a bioassay, and direct renin is essentially a form of an immunoassay in which you are measuring the renin content in that perspective. Now, very importantly, the renin activity will depend upon angiotensinogen, how much angiotensinogen is available there, and it is not affected via estrogen. So the major differences is if you talk about cyclical variation, you will have much more variation which happens in direct renin content as against a plasma renin activity. So during ovulation, if you want to look at PRA will be a much better strategy rather than a direct renin content from that perspective. Moreover, the assays are more robust for plasma renin activity. So most of us will go for plasma renin rather than a direct content. But if you are going with either of them, remember the ratios will be different. The aldosterone to renin ratio will be different and your interpretation will vary also from that perspective. So this is something important to identify what your lab is doing and how do you want to assay from that perspective. Very importantly, if somebody is restricting salt, or in a standing state, you will have an elevation of renin. Levels are typically highest in morning, and renal failure, of course, is a scenario where your renin will be less because it is being produced by the kidneys also in that perspective. Now, another very important problem which happens in these scenarios is that many of these patients are already on many medications. So what is the impact of those medications when you are assessing the aldosterone renin ratio? Because otherwise, you will get a false positive or a false negative result in that perspective. So if you have intake of spironolactone, essentially we're talking about calcium channel blockers, ACE inhibitors, ARB and spironolactone, all of them will suppress in a way aldosterone activity. So that will falsely give renin levels which will be high. So you will miss primary hyperaldosteronism. On the other hand, if your renin is still low, in somebody who is on ACE inhibitor, on ARB or spironolactone, you are 100% sure that this is a low renin or an endocrine pattern of hypertension. If somebody is on sympathetolytic agents, if you are beta blockers, central agents like clonidine, methyl dopa, these are all going to inhibit the central sympathetic trigger. So therefore, you will have a low level of renin, and because renin goes low, your aldosterone to renin ratio will go up. And you will falsely label somebody, okay, he does not have primary hyperaldosteronism, but you will say this is primary hyperaldosteronism. So these drugs should be avoided in that perspective. Direct renin inhibitor is not very commonly used now. That also causes a confusing scenario in which your PRA is less because you are antagonizing renin. So your bioactivity is less, but your immunoactivity is normal, because your renin content will be normal, but this is something which is not really commonly used in that perspective. So what do? We shift them to drugs which do not affect these ratios, which could pretty much be an alpha blocker like prazosin or a calcium channel blocker like verapamil, which can be there. So prazosin is a good drug to start off in that perspective. Now, very importantly, if somebody is on spironolactone, somebody is on ACE inhibitor, somebody who is on ARB, you expect them to develop hyperkalemia. If they are hypokalemic, then that is something that this is actually overriding the effect. This is 100% sure that this is an endocrine form of hypertension or renin excess, which is there in that perspective. Now, when you're assessing the RAAS system, you need to remember that like FT4 and TSH, like calcium and PTH, like glucose and insulin, there is a log linear relationship between aldosterone and renin activity. If your aldosterone level goes up, renin should be zero. So you have to basically correlate between aldosterone and renin, and they have to be done parallelly in that perspective. So if aldosterone is high, PRA level should ideally be low in that perspective. This is primary hyperaldosteronism. If, however, your PRA is high, it means renin is driving the whole picture. And this would mean something like a renal artery stenosis sort of a scenario. Now, how do you interpret this? So what I'm doing now is to use PRA, plasma renin activity, which is more commonly used. And I would prefer that because it's a better bioassay. And the ratio between aldosterone and plasma renin activity, which is ARR, or plasma aldosterone to plasma renin ratio. If aldo is more than 10 and renin is undetectable. So theoretically, whenever we say your FT4 is high, TSH should be 0. If your aldo is high, your renin should be 0. This is classically primary hyperaldosteronism. You don't need to worry about this in a great extent. However, if the renin is high and the aldosterone to renin ratio is less than 10, this suggests a hyperrenemic state. And we'll talk about both scenarios. If both of them are low, this means that there is some other form of mineralocorticoid which is acting, which could be a DOC, or there is an apparent mineralocorticoid excess, or Liddle syndrome. These are the possibilities which will be there from that regards. So now if we compare the common etiology in the form of renal artery stenosis, adrenal adenoma, or hyperplasia, these are pretty similar. GRA, these three will be similar. CAH variants, AME and Liddle, renin level will be low in everybody except a renal artery stenosis. So in this scenario, your renin is high because that is driving the overall picture. If we talk now about the aldosterone level, the levels will be high in everybody except for apparent mineralocorticoid excess, Liddle syndrome, and CAH variant. So if you have low renin, low aldo, you're talking about either DOC, or you're talking about 11 beta HSD or Liddle syndrome. And finally, if you have renal artery stenosis, CT angio will give you a clue. For adrenal adenoma hyperplasia, CT becomes important. For CAH variants, as we'll discuss, there would be the option of doing the specific metabolites. For AME and Liddle, you can use the impact of spironolactone. Now, if somebody is responding to spironolactone, it suggests an apparent mineralocorticoid excess. If they are not responding, this suggests a Liddle syndrome. And now, of course, genetic diagnosis can also give you the precise diagnosis in the form of a clinical exome sequencing, which you can do. So the approach to an individual who presents to us with suspected endocrine hypertension is to look at the renin level. If the renin level is high, possibility is renal artery stenosis, go for a CT angio. If the renin level is low, go for DOC level. If DOC is high, this is 11 or 17 hydroxylase deficiency, go for a tumor, go for CT and genetics. If you have got low DOC and your aldosterone is high, this is primary hyperaldosteronism. So low renin, high aldo, then you go for CT, and then young patient, family history of recurrent strokes, think of a GRA. So response to steroid will be significant. If you have got a low renin, low DOC, low aldosterone, this is either two differentials. You're thinking of either an apparent mineralocorticoid excess or a Liddle syndrome. Look for spironolactone response. If it's there, it's most likely a 11 beta HSD2 defect, which is apparent mineralocorticoid excess. In this case, you can do a genetic study. And if you have got no response, this is most likely a Liddle syndrome and you have to go for a genetic study. So basically, go for a combination of renin and aldosterone. These two will give you a clue. DOC will also be helpful, and then spironolactone response. High renin, renal artery stenosis, low renin, high DOC. You got specific diagnosis, but you will get clues. If there is a XX DSD, think 11. If it's a XY DSD, think of a 17. If, however, these are not there and your LDO is high, look for an adrenal tumor. If your LDO is low, look for spironolactone response and you will get the diagnosis.
This was a case 7 years and 4 months child. She came to me for only fever, cold, cough and vomiting for 2 days. It was a routine OPD visit, and in routine OPD, we have made a habit that we'll take a blood pressure of all the children who are above 4 or 5 years of age. And they have sensed that her BP was sky high, means 182 by 104. So we didn't believe initially that it was so high. So we have to take repeatedly. And I have asked her to stay in my OPD unit only up to evening because it was a Saturday. I remember that it was the 10th of December and we made her to wait until evening. And in the evening also, her fever reduced, but BP continued to have higher than 95th percentile. So the past history is, this is the first product of non-consanguineous marriage and ASD device closure done in February 2020. So our initial thought was whether we are dealing with cardiovascular anomaly, but because one is there, ASD closure was done, whether we are dealing with some other anomaly which is associated with the cardiovascular. So at that point, we have seen, and it was already been told that it is more than 95 percentile plus 12, means it is very high. The diastolic should be 122 and systolic should be 122 and diastolic should be 84 for that age, 7 years. And she was above that. Repeated examination shows that it is in between 126 by 80 or 134 by 84, like that. But as that was a Saturday, we asked her to come on Monday because she had not come for any complaints related to the hypertension as such. And on Monday also, she was hypertensive. So we did a routine CBC and urine because next comes the renoparenchymal disease. One is cardiovascular, second is renovascular, then renoparenchymal, then endocrine. These are my thoughts initially in OPD. And blood urea serum creatinine was normal, urine was normal. That's almost also renoparenchymal because she didn't have any edema. The weight was normal, height was normal for that age, 7 years, 118. No tachycardia, no flushing to rule out phlebochromocytoma, no skin rash for HSP, Henoch-Colin purpura or any vasculitis, no joint swelling like arthritis. And genitally, afterwards we have seen this, there was no palpable gonads because she was a female child. After that, we have come renal, endocrine, neurological, vascular, pharmacological, and psychogenic. She was not on any drug. So that was also ruled out. And we have taken, there was a past history of ASD closure. So cardiovascular etiology for hypertension was looked for. Femorals were palpable. Both were equally palpable. So there was no coarctation or no interrupted aortic arch. There were no bruit over the abdomen to rule out renal artery stenosis. Well-grown child. She went for device closure and they injected dye. So we thought that whether that dye has caused something like CKD. But blood urea serum creatinine and her growth has ruled out that. Renoparenchymal versus renovascular was a thinking. No edema over the eyelids or no edema anywhere else also. And urine was absolutely normal. So we were in dilemma. So to think of renovascular, we have, but there was an interesting history that came to me, that family history is there. The maternal uncle, Miss Mama, is suffering from autosomal dominant polycystic kidney disease. His maternal aunt, Mausi, is also suffering from autosomal dominant polycystic. And 5 or 6 grandfathers from maternal side are ADPKD. And they all died. 6 of them have died at the age of 52 to 65. Means there was a type 2 of that ADPKD because later onset. And I searched the articles that ADPKD, whether ADPKD and this child's hypertension can be correlated, but it didn't find anyone. So we decided to go for initially ultrasonography of abdomen to look for any tumor inside, adrenal or near the, or something wrong with the kidney. And renal Doppler was requested to look for the renal artery stenosis. That is not that sensitive or specific, but that is a easier available method before going to CT abdomen. So, but he could not do it because he could not hold the breath for a few seconds there. That was required to do renal Doppler. And he said that ultrasonography is in kidney, there is bilateral nephrocalcinosis. So I was surprised by this finding, because a nephrocalcinosis, I know that it is only some renal tubular acidosis. And then I searched causes for bilateral nephrocalcinosis with hypertension, and there are so many. All tubular disorder can cause, whether there is hypercalciuria, they can cause renal nephrocalcinosis in this child. So with this, the next investigation was to do VBG and electrolytes. So we have done VBG, and it shows that she is having metabolic alkalosis with hypokalemia. 2.3 was my initial reading. Then we again send him to adult endocrinologist in Kolhapur to do PRA aldosterone level, and at that it was going down to 1.7. So that endocrinologist and myself were very much worried, but the parents were not that worried because the child was stable. There were no cramps, no palpitation, no headache, nothing wrong with the child. And they blamed us that this child is now slightly looking ill because of your repeated probes, injections, or taking blood samples. So for 1.7 potassium was literally worried and phoned them to come to me and get at least IV calcium so we can raise slightly. We have to find out the cause, but cause can be found out later on, but your potassium should be slightly better, not below 2.5. I said that. And they were ready to come to me after counseling, and it was on the 6th day, because I have diagnosed this on the 10th of December. They came to me on 16th of December. Exact, that was on Friday, I remember. And we admitted that child and started with IV potassium, Kesol. And she had a metabolic alkalosis with hypokalemia, was suggestive of RAAS excess. And we have done a urinary potassium to creatinine ratio, which was 28, and which suggests that she is losing the potassium from the urine. So your slide, sir, I have taken the hypokalemia, urinary loss. Either we are dealing with the RAAS excess, or as Liddle syndrome, or 11-hydroxy, or 17-hydroxy. So this was these 4-5 were our differential diagnosis at that point of time. And then what we did, this was done at the Kolhapur, ACTH, cortisol, aldosterone. Aldosterone was not that high. And plasma renin I have not mentioned, but it was less. Direct plasma was less than 0.5 picogram per ml. So it was also low. Low renin, low aldosterone, slight normal aldosterone actually. And we have done this Centropac stimulation trace. On the 16th of December, we have taken one sample, and after stimulation, after 1 hour, we have taken on 17th of December. And you can see that corticosteroid is sky high and deoxycorticoid is sky high. Cortisol is very, very low. Testosterone, estradiol, they are very low. 17 OHP also very low, not that high. After Centropac, it has come down 126. That is slightly marginally high, but not that high. So we have this. I have explained to my parent, to the child's parents like this. I have printed this. I have said that cortisol is low. That's why we'll give high zone. Testosterone, these are low. So there is a block here. And these are the yellow marks. These are the higher. So we are either dealing with 17 OH deficiency or 1720 lyase deficiency. And we'll send the clinical exam sequencing. We have started with spironolactone and K-sol initially. Then this report came as clinical exam sequencing proved that we are dealing with 17 alpha hydroxylase deficiency or 1720 lyase deficiency. It is difficult to differentiate between them. I would like to hear from you, sir, now. And she's on, this was hypertension, hypokalemia, metabolic alkalosis, low cortisol, estradiol, DHAAS, and high corticosterone and deoxycortisol. So 17 alpha hydroxylase deficiency / 1720 lyase deficiency, and she is on hydrocortisone 10 milligram per meter square, aldosterone 2 to 3 milligram per meter square per kg per day. Last follow 15 days ago, her blood pressure is absolutely normal, 110/76. Initially, we have started with potassium supplement, but after this report, serum potassium has been normalized and that to higher side now, 5.5 milligram. We have stopped potassium. Now she is solely on aldosterone and hydrocortisone only. So with routine OPD blood pressure checkup, we have done mandatory and we have picked up this case without any complication. Thank you, sir. This is a child.
Of course, which you raised was whether it is a 17 hydroxylase / 17 lyase defect. So essentially speaking, it's a single enzyme. So the same enzyme is doing both hydroxylase and lyase. The difference in the activity depends upon the electron donors. How many electron donors are there? That will decide about whether it's a predominant hydroxylase activity or a lyase activity. There are certain recent onset diagnoses and forms which have been identified, which are basically in the electron donors, which can present like a isolated lyase deficiency, but that entity is not considered to be a separate entity. Now, if you're talking about hypertension, if you're talking about DOC and other excess, it is clearly a complete enzyme block. So it's a complete block of the enzyme which is there. So this is, I would say, the 17 hydroxylase deficiency. And the treatment is pretty much hydrocort. I would assume that you should be able to stop aldosterone soon. Otherwise, there will also be a risk of hyperkalemia. So you need to be cautious in this regards, because once you treat the underlying cause, you give a physiological supplementation of hydrocortisone, most cases will improve. So maybe try to taper out aldosterone and monitor potassium carefully. The other big thing, of course, would be that there will be long-term estrogen deficiency, because they will not be able to produce estrogen. So she would present basically with delayed puberty subsequently. So we had the similar case which presented in later age group, and we probably we'll have some couple of presentations quickly onto that. But she would have presented later with delayed puberty and hypertension if we had not picked up. But this case was so severe that this hypokalemia would have caused a problem. So I think this was a very, very interesting scenario.
And one more question, sir.
Yeah.
And what should be monitored? Means whether we have to monitor deoxycortisone or some this has to be monitored lab-wise.
So I would say even for 21 hydroxylase, we are now talking more in terms of the clinical monitoring. What we're talking about is that you have to monitor for the blood pressure, for the Cushing-White phases, for electrolyte. Same here, I think you need to go more for clinical parameters. What is our blood pressure? What is our
blood pressure and electrolytes?
That will be pretty much the most important clue to go forward. If you want to really look at in terms of follow-up, then PRA, if the PRA has become detectable, all those things. But I would say main blood pressure and potassium will be a good enough clue in that perspective. She would need pubertal induction at the right time. And that is pretty much the case. And otherwise...
One more issue I have not purposefully highlighted, that uterus and ovaries were not detected on ultrasound, but uterus at this stage is papery thin, may not be detected. And then that's why I have not highlighted that issue. But so we have to do karyotype in this child.
So that's what I had mentioned to you, that probably karyotype may be required, but you did not find any palpable gonads which were there. So I would be cautious. I would be cautious later on as well, that we need to do a karyotype if she doesn't develop. But since palpable gonads are not there, it looks more likely to be an XX individual. But 17 hydroxylase, the most severe XY individual will present exactly like this. So I would be cautious about that possibility and feel for gonads, look for maybe abdominal gonads, do a karyotype. But I believe that if the NGS has been done, they should have been able to report that if the gender was not fitting, they would have mentioned that the child does not fit into a female one. So you can maybe ask them. So that will be the...
I will ask them.
So they should have been able to tell you that this is SRY and all those things will be present. So they will know what the gender is basically. So that will be...
I will ask them.
So otherwise, ideally karyotype will be helpful. Old boy with high blood pressure, potassium was 2.4 and renin was low and aldosterone level was high. So this is actually a primary hyperaldosteronism in a 16-year-old boy with hypokalemia. So we are thinking of something else. So we'll ask for the family history. There was a family history of premature stroke in multiple family members. and the workup showed a normal adrenal CT scan. So what are we thinking about, Dr. Dhwani?
We are thinking of glucocorticoid.
So we are thinking of a glucocorticoid responsive form, older age of onset, family history, hypokalemia, and detectable aldosterone. So the genetic diagnosis confirmed that, and we started on steroids, with which there was improvement. 8-year-old boy with hypertension, blood pressure was very high, potassium was low, and there was metabolic alkalosis. So Dr. Vibha, we have got hypertension, hypokalemia, and alkalosis. In this boy, no renin, no aldo. So low renin, low aldo. What are you thinking about?
So then we have to see the spinal response. As the boy is older, then it is most likely AME.
Okay.
Could be.
Now, anything else? There was no gonads and there was a uterus.
So we have to see the DOC level.
So this will be this DOC group. So you have an 8-year-old boy with hypertension and who has got uterus there. So this is actually a XX-DSD, and you are dealing with a 11-hydroxylase deficiency. You can all go and have a look at our website and explore our courses and the mobile application.